inviting Dr. Geetha IYER, who needs no introduction for extensive work on ocular surface diseases, to present on a very important topic, that is the ocular chemical injuries, because the treatment of that is at primary care setting, and if that's not managed well, then that's where the tertiary care setting comes in. So the primary management and also the tertiary management is very, very important. Dr. Geetha IYER.
A very good morning to one and all of you. Thank you, chairpersons, for your kind introduction and for this opportunity to speak on a very important topic of ocular chemical injuries. Today, I will be sharing certain newer insights into the management of chemical injuries, especially the acute chemical injury and especially those belonging to the very severe grades where standard treatments often fall short. I have nil financial interests to declare. The primary goal in management of acute chemical injuries is to retain or regain limbal stem cell function and corneal clarity. This is largely achievable in mild to moderate injuries. However, in severe cases where significant limbal damage occurs, the conventional yardsticks of success, such as epithelial healing, symblepharon formation, the severity of limbal stem cell damage, corneal scarring, and the need for keratoplasty, are significantly delayed and high. Although amniotic membrane transplantation is widely accepted and favorable in moderate injuries, its role in severe chemical injuries is questionable. A review of literature that we did dating back to 2001, including the work by Dua et al. In 2001, followed by the Cochrane Database Systematic Review in 2012, followed by the randomized controlled trials from our very own RP Center here in India, or the randomized controlled trial by the Holland et al. Group, has always shown basically that the outcome of severe chemical injuries is very poor, and amniotic membrane does not accelerate the healing in patients with severe chemical injuries. Our own study of 38 severe grade chemical injury cases treated with amniotic membrane alone showed poor healing outcomes. And the reason for this is basically the fact that when you have a very large defect on the ocular surface, then the time that it takes for the epithelium to heal, especially when you do not have any residual cells on the epithelials on the ocular surface, is long, which leads to a non-healing epithelial defect, which in turn leads to sequelae of the same in the form of corneal scarring or corneal thinning, and sometimes even corneal perforation in the central part of the cornea. And this is where we basically highlighted the role of adding cells onto the ocular surface in the form of AIOS2025, which is what we introduced, the early stage allogenic simple limbal epithelial transplantation, to provide a cellular cover over the amniotic membrane, which aligned with Professor Dua's observations for the need to add cells in patients with severe chemical injuries. Retrospective analysis of our own series comparing AIOS2025 to amniotic membrane alone showed a significant improvement in all the yardsticks of success, as you can see here, whether it be the time to epithelialization, or whether it be the severity of symblepharon that these patients developed, or the severity of LSCD that these eyes developed following the use of AIOS2025 in severe chemical injuries, with a comparison of outcomes in the amniotic group alone versus the AIOS2025 group. The epithelial healing occurred almost 9 times faster with AIOS2025, and the odds of complete epithelial healing occurring within 30 days in the AIOS2025 group was 6 times more than just the amniotic membrane group. This basically highlights the importance of rapid epithelialization in acute chemical injury, especially in patients with severe grades, which can be effectively achieved with early stage AIOS2025 in chemical injuries. And this is basically our goal, to achieve quick epithelialization. Effective management ultimately requires an effective classification system. When you look at the existing grading systems for chemical injuries, the focus is primarily on the epithelial defect, but the epithelial defect which only involves the limbus and the conjunctiva and does not comprehensively capture the factors which influence outcomes, because epithelial defect is not the only parameter that affects the outcome in these eyes, and barely addresses what an ideal classification system should offer. So when you look at what the current grading systems offer in terms of the disease direct effects or any of the other parameters that give you an understanding of what the final outcome would be, we do not have a grading system that accurately captures most of these parameters. To bridge this gap, we proposed an algorithmic approach based on key influencing parameters, which we termed as the I's and E's of management, where you're not just looking at the epithelial defect, but also at the inciting agent, the inflammation, the ischemia, the intraocular pressure, and the exposure, all of which together have an impact on the rate of epithelial healing in these eyes and subsequently the final outcome in these patients. From this, we developed what is called as EPICS, an enhanced grading system for acute burns, which is what we published. And building on this, we have now created what is called as the D-code score for not just acute injuries, but also for chronic injuries. And in the acute burns, it evaluates the conjunctival as well as the corneal epithelial defect, the ocular surface ischemia, the digital tension, and the exposure. And this is a short video that highlights the various parameters that are actually captured online on this system, which is freely available to use at codeicare.org, where you have all the grading of every parameter that has an impact on the final outcome in chemical injuries, which is captured along with the demographics, which is what D stands for. And when you click on the evaluate, it gives you what is called as the code score, and this is the dynamic printout which can be taken for the patient as the healing evolves, and you will have an understanding of how the patient is basically responding to your treatment. This is the printout. It is more comprehensive than the existing classification systems. It integrates seamlessly into the EMR documentation, where you just need to upload the PDF. It actively guides treatment decisions, reducing complications from overlooked factors, and it reinforces the goal of returning to code 0, ensuring optimized recovery. It is freely accessible, and this is basically to highlight again and emphasize the importance of the D-code score, which is a comprehensive score generator for patients with acute chemical injuries. Why do we really need something like this? Because when you look at two patients of similar severity of chemical injury, one on the left and one on the right, the outcomes have been totally different, because it depends on the laterality, it depends on the ischemia, it depends on the exposure and the intraocular pressure. Each of these parameters which need to be addressed appropriately and aggressively in the acute stage to ensure that you have a good outcome. Both of them ended up with a vision of 6.6 or 6.9 in their eye which was affected, but you can see that one required a keratoprosthesis with an Ahmed glaucoma valve with tenonplasty and alloslet in the acute stage, versus another which was a unilateral injury which did not require any of these other measures. So when you look at the D-code score in comparison with the current grading systems, it provides you information on most of the parameters that are lacking in the current grading systems, and it is the next logical step to the existing classification systems, is dynamic and it is user friendly. Not just for acute injuries, but the D-code is also something that we have modified for the chronic ocular injuries, where decision making is largely based on the laterality as well as the tear status, in addition to the extent of limbal stem cell deficiency. And this was an algorithmic approach that we had published for unilateral total limbal stem cell deficiency following a chemical injury, and bilateral total limbal stem cell deficiency in the APJO. And this gives a very clear understanding of the algorithmic approach to these patients, especially in bilateral total limbal stem cell deficiency, where the decision needs to be taken with regards ocular surface reconstruction vis-a-vis keratoprosthesis, where again there is an algorithmic approach to choosing the right type of keratoprosthesis in every patient based on the anterior segment, the posterior segment details, the psychosocioeconomic factors, and the immunological condition of the patient. And this is a short video which shows how we grade the chronic ocular burns based on several parameters, which include the laterality, which again includes the CODE, where C stands for the conjunctival shrinkage. O basically represents all the factors which affect the circular limbus, which is not just your extent of limbal stem cell deficiency, but also your tear status, whether the surface is moist, dry, or keratinized. It also gives you an idea of what the digital tension is, and also allows you to give an estimate of what the visual potential could be in that particular eye based on the presence of glaucoma, RAPD, phthisis, the posterior segment status, and anything else which might compromise the visual potential in these patients, and therefore gives you a scoring which helps you counsel the patient as well as the family more effectively with regards the choices that you have for management, as well as the option or prognosticate with respect to the visual recovery in these patients. With the use of these kind of criteria for both acute as well as chemical injuries over the years, we today have several options even for end stage, very severe grade chemical injuries, and this is to highlight some of our patients of chemical injuries whom we have been able to rehabilitate with the help of the various types of keratoprosthesis, the OKP or the type 2 or the type 1, where these patients have regained back visual potential to become self-ambulatory and to get back some amount of normalcy. After establishing Code Eye Care, an Institute of Excellence for Cornea, Ocular Surface and Dry Eye in Chennai, we continue to follow up and take care of these patients with very severe bilateral end-stage ocular surface disorders, the type 2 K-pros, which we today have an experience of close to 88 keratoprosthesis, and the modified osteoodontokeratoprosthesis, where our cumulative experience stands at 131 cases so far. So to summarize, these are some of the newer insights into chemical injuries, where there is a role of alloslet in severe grade chemical injuries and the decode scoring system, which helps us to grade not just acute chemical injuries, but also for chronic ocular injuries. And I would reiterate that these kind of grading systems are very essential to understand the existing status of the eye and the appropriate management in these patients. I would like to thank the entire team back home in Chennai at Code Eye Care, my work sibling, Dr. Bhaskar Srinivasan, and the entire team at Code Eye Care, our mentors and our patients. And I would also like to take this opportunity to invite you all to the Keracon 2025, the annual meeting of the Cornea Society of India, to be held in Goa this December. Thank you.